Welcome back to the Deep Dive. Today we're tackling something that, well, it can be really unsettling. Dizziness.
It really can. That feeling when your balance just goes, it's instantly worrying, isn't it?
Absolutely, your mind just races.
Yeah.
So what we want to do today is look at the professional guidelines, sort of unpack them for you.
Exactly. Offer some clarity, maybe some reassurance too, based on how doctors approach this. Because while you're right to want serious things ruled out,
There's good news.
there is. Let's start with a key statistic from general practice. Dizziness is very common. We're talking about maybe 35 patients per year in a typical practice.
Okay, so doctors see a lot.
They do. And crucially, the chance of something really serious being the cause, it's actually low. And the outlook, the prognosis, is often pretty good.
Honestly, that's good to hear right at the start. So the guidelines, they break dizziness down.
Yes, into three main types, based on the sensation. Getting this right is, well, it's the cornerstone of figuring out what's going on,
Why is separating them so vital?
because it points you in the right direction. Is it the inner ear? Is it more circulatory? Or something else entirely? Mix them up and you're chasing shadows.
Okay, lay out the three pillars for us.
First up is vertigo. That's the real spinning feeling.
Like the room is moving.
Or you feel like you're spinning. It's often intense, might come with nausea, feeling pale, anxious, those vegetative symptoms. Classic inner ear territory.
Got it. Spinning is vertigo. What's number two?
Number two is presyncope. Think lightheadedness, that floaty feeling like you might faint but don't quite.
Ah, the near faint. So
Yeah.
more like blood flow related.
Often, yes. A temporary dip in circulation, perhaps.
And the third one?
That's disequilibrium. This is more about feeling unsteady on your feet, wobbly.
But not spinning, not faint.
Exactly. And the key thing here is it usually goes away when you sit down. It's about physical instability when you're upright. Keeping those three distinct is step one.
Okay, that framework makes sense. Now, who tends to get dizzy? Are there patterns?
Oh, definitely. Epidemiology shows women report dizziness about twice as often as men, generally speaking.
Interesting. Any other factors?
Age is the big one. It ramps up quite significantly as we get older, get past 85, and the rate's pretty high, maybe 8% per year. And up there, the gender difference kind of levels out.
And with older patients especially, there's this diagnosis. Aspecific dizziness. Sounds a bit like a catch-all.
It kind of is, in a way. For a lot of older people, maybe a third of them reporting dizziness, you can't pin it down to one single cause. It's multifactorial.
So no easy answer sometimes.
Right. It means the approach has to be broader, looking at multiple contributing factors. We'll come back to that.
Okay, let's dive into that first category then, vertigo, the spinning. You said inner ear. What's the most common culprit?
By far, it's benign paroxysmal positional vertigo, BPPD for short.
Benign, paroxysmal, positional. Okay, break that down.
Benign meaning not harmful. Paroxysmal means it comes in sudden, brief spells. And positional because it's triggered by head movements.
What's actually happening in the ear?
You have these tiny calcium crystals, otoconia, in your inner ear. In BPPD, some break loose and drift into the semicircular canals where they shouldn't be. They mess with your balance signals when you move your head certain ways.
So what kind of movements trigger it?
Classic ones are rolling over in bed, bending down, or looking up high. The dizziness itself is usually very short seconds, maybe up to a minute.
How common is this BPPD?
Pretty common. Incidence is around 1.6% in the general population. But the good news is most cases, maybe even the majority, clear up on their own within about 4 weeks.
Okay, so BPPD is brief, mechanical, often resolves.
Mm-hmm.
What if the vertigo attacks are longer and there's hearing involved?
Then you start thinking about Meniere's disease. This is different. It's characterized by recurrent attacks of vertigo, but these last longer, 20 minutes to several hours.
And the key difference is the hearing.
Yes. Plus, crucially, you need documented hearing loss, typically in the low frequencies, and tinnitus, ringing, or fullness in the ear during or around the attacks. That triad is key.
What's the long-term picture with Meniere's?
Well, the vertigo attacks themselves often become less frequent over many years, which sounds good. But the hearing loss is usually permanent and tends to get progressively worse. That's a major distinction from BPPD. Requires careful monitoring.
Okay. Then there's another cause of sudden, severe vertigo.
Yes, vestibular neuritis. This is different again. Think acute, constant, really severe vertigo that can last for several days. It's often thought to follow a viral illness like a respiratory infection.
How do you tell that apart from, say, Meniere starting suddenly?
The absolute key is Vestibular neuritis does not cause hearing loss. It's an inflammation of the vestibular nerve, affecting balance only. Usually hits people aged 20 to 60.
No hearing loss. Got it. And there's one more vertigo cause that's relatively newer in the guidelines.
Right, vestibular migraine. This has gained a lot more recognition. It's episodes of dizziness or vertigo lasting anywhere from 5 minutes to maybe 72 hours.
And the link is migraine.
Exactly. It happens in people who have a history of migraines. Importantly, you don't necessarily need to have a headache during the dizzy spell itself.
So how do you differentiate that, especially for Ménière's, if the attacks are episodic?
The big clue is the hearing. Vestibular migraine does not cause progressive hearing loss. If someone has recurring dizzy spells but their hearing tests stay stable over time, you lean much more towards vestibular migraine than Ménière's. That's a vital distinction.
Okay, that covers the main spinning culprits. Let's switch gears to the second type, presyncope or lightheadedness, the almost fainting feeling.
Right. This points us towards circulation and blood pressure issues, often transient ones.
Like what sort of things?
Could be a vasovagal response, triggered by stress, pain, strong emotions, even just standing for a long time. Or it could be orthostatic hypotension or medication.
Hey, let's focus on orthostatic hypotension, or OH. That's the dizziness when you stand up, right?
Correct. And it has a very specific definition. Your systolic blood pressure drops by at least 20 points, or diastolic by 10 points, within 3 minutes of standing up. It has to be measured.
Okay, clear definition. But I think the guidelines mention something surprising about this.
They really do. It's quite counterintuitive. The research shows there's actually only a weak link between someone feeling lightheaded when they stand up and actually having that measurable blood pressure drop, the OH.
Wait, really? So you can feel dizzy standing up, but not technically have OH based on the numbers?
Yes. Or, conversely, you might have the measurable drop but not always feel symptomatic. The symptom doesn't perfectly predict the measurement.
So what does that mean practically?
It means you can't just rely on the feeling alone to diagnose OH. You need the measurement. However, and this is critical if someone does have measurable OH, whether they feel it every time or not, they are at a significantly higher risk of falls, cardiovascular problems, and even mortality.
Wow. So the objective number matters a lot, even if the feeling isn't always there.
Precisely. The measurement itself flags a risk.
You also mentioned medications. That seems huge, especially for older adults.
It's massive. Medications are implicated in maybe up to 25% of dizziness cases in older people. There's a whole category called fall risk-increasing drugs, or FRDs.
FRDs. What kind of drugs are we talking about?
It's a long list, unfortunately. Antipsychotics, antidepressants, benzodiazepines, sleeping pills, and anti-anxiety meds, antihypertensives, so blood pressure drugs, including beta blockers, opioids for pain, even some diabetes medications.
That covers a huge number of commonly prescribed drugs.
It really does. It strongly suggests that if you're dealing with persistent dizziness, especially if you're older, a really thorough medication review is, well, it's essential, looking specifically at these FRIs.
Are there any meds linked specifically to the spinning type, the vertigo?
Yes, some evidence points to certain ones. Aminoglycoside antibiotics like gentamicin, also azithromycin, pregabalin, which is used for nerve pain and seizures, and some alpha blockers used for blood pressure or prostate issues. Those have been linked more to vertigo specifically.
Okay. And before we leave lightheadedness, the mind-body connection, anxiety, depression.
Absolutely crucial. Dizziness is a very common physical symptom in anxiety disorders, particularly panic attacks. And in depression, too.
It can be a cycle, right?
A real vicious cycle. Anxiety can cause that lightheaded feeling directly, but also experiencing chronic dizziness, whatever the initial cause, can understandably lead to significant anxiety, fear of movement, avoidance, which then makes everything feel worse. It's complex.
Okay, let's move to the third category. Disequilibrium, that feeling of being unsteady.
Right, the wobbliness.
Yeah.
This is seen mostly in older adults, and as we touched on, it's often multifactorial. Not one single thing wrong.
So what kind of things contribute?
Could be joint problems like arthritis, muscle weakness, problems with vision, or underlying neurological issues like Parkinson's disease, for example. It's more about a general sense of being unsteady on your legs.
And the key differentiator again.
It typically vanishes when you sit down. The instability is primarily when upright and moving. It really highlights how balance relies on so many systems working together.
Okay, so we have the three types. Now let's talk urgency. When should dizziness trigger alarm bells? When is it an emergency?
The absolute priority is ruling out central causes, meaning brain issues like a stroke or a TIA, a mini stroke.
What are the red flags for that?
The biggest red flag is sudden dizziness combined with any new neurological symptom. Things like slurred speech, double vision, sudden weakness or numbness on one side, or ataxia that's like severe incoordination, trouble walking straight.
So dizziness, PLUS, something neurological equals emergency.
Yes, get checked out immediately. If it's just sudden, severe vertigo with absolutely no other neurological signs, the risk of stroke is lower, but any accompanying sign warrants urgent assessment.
Okay. Assuming it's not an emergency, what are the go-to diagnostic tests for the common causes like BPPD?
For BPPD, the classic test is the Dix-Hallpike maneuver. The practitioner moves your head and body in a specific way. If it triggers that characteristic brief vertigo and causes specific jerky eye movements, called nystagmus, that confirms BPPD.
And for that acute, constant vertigo without neurological signs, like vestibular neuritis.
Specialists might use the head impulse test, or HIT. It helps differentiate if the problem is peripheral in the ear or potentially central in the brainstem or cerebellum, though it's often more of a specialist tool.
Now, treatment. This is where it gets really interesting, especially regarding non-drug approaches. For BPPD, the most common cause.
The fix is mechanical. It's the Epley maneuver. It's a specific sequence of head and body movements designed to guide those loose crystals out of the canal and back where they belong.
And it works.
It works remarkably well. The guidelines say over half of patients feel better after just one Epley maneuver. It directly addresses the mechanical problem. Sometimes it can cause brief nausea during the maneuver, but it's highly effective.
What about chronic dizziness or balance problems, lasting more than a month?
Then the recommendation shifts to vestibular rehabilitation, or VR. This involves a program of specific head, eye, and body movement exercises done daily.
How long does that take?
Usually over about 6 to 12 weeks. But here's a really important point from the research. Study suggests that doing VR on your own, using good instructional materials like videos or handouts, is likely just as effective as doing it with a therapist guiding you every time.
That makes it much more accessible.
Exactly, empowering people to manage it themselves.
Okay, let's get to the medication point because this seems like a big takeaway.
Yeah.
What do the professional guidelines actually say about common anti-vertigo drugs like beta-histine, cinerazine, flunarizine?
This is probably the most practice-changing finding for many. The guidelines are very clear. They do not recommend using these anti-vertigo medications for general dizziness or vertigo.
Wait, so beta-histine, which is often prescribed?
Not recommended based on the current evidence. The studies just haven't shown they're effective for most types of dizziness, and they do have side effects. Flunarizine, for instance, has been linked to drug-induced Parkinsonism.
What about specifically for Ménière's disease? Beta-histine is often used for attack prevention there.
Even for Ménière's, the recommendation has changed. High-quality research, specifically the BMED trial mentioned in the sources, found that beta-histine was not effective in preventing attacks compared to placebo.
Wow. So the evidence really isn't there for these meds in most cases.
That's the conclusion from the guidelines. The focus should be on accurate diagnosis, specific maneuvers like the Epley for BPPD, vestibular rehab for chronic issues, and addressing underlying factors like medications or orthostatic hypotension.
So wrapping this up, what's the main message for you, our listener?
I think it's about empowerment through understanding. Knowing whether you're experiencing spinning, lightheadedness, or unsteadiness helps you and your doctor target the right cause. And for the most common cause, BPPD, there's a really effective non-drug fix.
And for that lightheadedness on standing, the orthostatic issue, you mentioned simple things people can do.
Yes. If OH is suspected or confirmed, learning simple physical countermaneuvers can make a big difference in preventing falls. Things like tensing your leg and buttock muscles before you stand up, or crossing your legs tightly while standing, or even doing a quick squat can help maintain blood pressure.
Practical tips. Okay, final thought. Let's circle back to that significant group, especially older adults with a specific dizziness, where pinpointing one cause is hard. What's the takeaway there?
It really underscores that sometimes, particularly with complex issues in aging, you have to shift focus. Stop hunting for the single magic bullet cause. Instead, adopt a systematic approach. Meaning, you look at all the potential contributing factors. Is vision optimized? Is muscle strength adequate? Can medications be adjusted, those varices? Are there anxiety or mood issues to address? Is balance training needed? It's about managing the whole person and reducing the cumulative burden of deficits rather than just treating one symptom.
So for complex dizziness, the solution is often managing multiple smaller problems.
Exactly. Treating the person holistically, not just chasing the dizziness itself. That's often the path forward in those more challenging cases.